So over the last year or so, what really excites you most for our patients with follicular lymphoma? What are some of the things that that you think are going to hopefully come to fruition and change the way we're treating patients? So I'll start with you.
Yeah, I think, the biggest advance is probably, well, there's two things. One is that follicular lymphoma is not just one box. I think we're understanding more that there are subsets and that perhaps these subsets need to be approached a little bit differently. So, we talked about how at the beginning we use clinical criteria, but we now have this time-based definition of poor outcome, early progression. Some of the trials have been very advanced and really focused on this double refractory population. And I think by kind of learning the different phases of the disease, I think that's an important advance to try to get more tailored therapy. And then the other piece is just that we have some more non-chemotherapy options. And that opens up a tremendous number of possibilities.
Wouldn't it be great if we knew who those patients were before that would really save a lot of issues for us.
Absolutely.
Nathan?
So, I mean, actually, you had a nice segue there. I think, for me, the most exciting thing, again, are some of these novel regimens that are coming out. I do think that, thank goodness, we are seeing, in our career, we're seeing the natural history of this disease change. And, I don't feel that old, but it wasn't that long, at least when I came out of training, most patients still died of follicular lymphoma, and the median survival was around 10 years. So I think that all these things together are leading to an improvement in patients. I don't think any one single thing maybe you could bill as the victor, but I think that the next generation of studies is really going to be able to use molecular profiling of patients to do exactly what you said, really predict what's driving that tumor, predict the different clones that are within the tumor, as well as what's the right therapy. So I hope in the future we're not going to be doing these big phase 3 trials. We put everybody in the same bucket, but we can actually kind of stratify patients based upon what's driving the tumor.
Yeah, that's got to be the way forward. John?
Yeah. I'll take a totally different tack and just kind of emphasize something we've indirectly referred to, and that is that 80% of these patients are not going to die of their disease. So that is reassuring, and the issue of prognostic features and markers, if you could tell that patient that you're in that group, that would change the whole mindset around this disease. And in reality, quality of life for those 80% of people is the driving thing. So I'm hopeful that we are going to have better ways of measuring, tracking quality of life, whether it be through new technologies of smartphones and monitoring patients over the long term, or at least having tools that in our clinical trials we can say, well, it's better to have a chronic therapy with less toxicity but ongoing versus a more acute toxicity like with R-CHOP, that it tends to be more self-limited, and be able to measure this better and perhaps use some novel ways of presenting this to our patients so that they can make some differences. There are ways of presenting, your risk of a heart attack based on your cholesterol level, if you take a statin or not, that are pretty novel, and we don't use anything like that if we use these that presented this a little more vividly to patients, perhaps we can do it. So I'm hopeful that we'll get there. Again, a different tack, but I think our discussion has highlighted the need for something like that.
Yeah, are you doing anything like that in the Alliance yet, or is it still in the future?
We're taking some steps in that regard, and I think that more and more for cancer, I think these patient-reported outcomes and really metrics of quality of life, because we have PFS benefits, but we don't have overall survival benefits. And so what is the value of PFS? And that's in the eye of the beholder, particularly if it comes at a cost or a price of taking more therapy that's associated with some side effects.
Yeah, I think that's really important with the discussion we had earlier about rituximab maintenance or not. It is in the eye of the beholder, and I'm not so sure I know what my patients, how they're going to think about that. So important. Josh, how about you?
I will definitely agree with one thing that was said, which is I also don't think of Nathan as old. So we agree on that. and everything else I just. So, you know, in maybe, God willing, 5 years, we will have a chance to molecularly predict those early relapsers. But today, we can predict them with the common sense test of seeing who relapses early. And as was already said, we should just be doing randomized trials of those patients, the ones that are not the 80% that are going to live. I mean, we should just refocus all clinical trials towards the high-risk patients who do still need the benefit. And we're lucky to have, you know, mechanistically distinct approaches where if they were not responding well to chemotherapy, perhaps the response to something that works very differently to kill cancer cells can still work. You know, we talked about near-term things. In PI3K, we still have near-term advances to be made. We have 3 new, somewhat distinct PI3K delta-focused, probably more than 3, but 3 well into clinical trials already. One of them, umbralisib, I think already pretty far into it, and showing, surprisingly for me, a very distinct safety profile. So some of those PI3K deltas may actually change our thinking about what could be standard of care for those early relapsers. And then I think we have such promising early data for some of these immunotherapy combinations. Again, if a follicular lymphoma cell is resistant to chemotherapy, it may be still exquisitely sensitive to T-cell attack. So I think those are huge opportunities for the early relapsing patients. And God willing, in Nathan's career, we'll still be able to make more advances. Yeah.
Matt, and last but not least.
So I know Josh is going to make fun of me because I'm gonna bring up that we get to spend more time with our patients now, because we have more options. You know, coming back to, you know, just starting with relevance with gallium, you know, we have randomized trials now to talk to our patients about, to give them more options. And even though if you don't choose, you know, lenalidomide rituximab in the first line setting, it doesn't not mean that it's not a good regimen in the second line or the third line, as the Magnify trial, you know, has shown us. So, you know, there's PI3 kinase inhibitors, there's you know, lenalidomide rituximab, you know, and there's still, you know, good chemotherapy if that's what you choose for a fixed duration therapy. So, you know, I guess I'm going to be getting home later.
I see why your patients like you so much.
Yeah, the question of sequencing really is a challenge, and I can imagine it does take a long time. Well, thank you all for your contributions to this discussion. On behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative.